everyone. Welcome to the Weiner Wellness Week Virtual Summit. We are here today with Dr. Sonia McGowin, and she has a great presentation for us. She's actually spoke for us before on this platform, so we had a great response to her presentation. So we brought her back. We're really excited to have you. So she has a great PowerPoint for us to look through. It's a great tool to use to see what she's talking about. So I know you have a little bit of background in your PowerPoint, so I'll just share the screen now, let you introduce yourself a little bit and walk through your PowerPoint and just get to your topic that you have for us today. So thanks so much for being here with us.
Thanks for having me. All right, so like Candace said, my name is Dr. Sonia McGowin. And I'm going to talk to you today about how I approach Pans and Pandas in my practice. I am a chiropractor, and so I have sort of become the accidental expert on Pans and Pandas. That, you know, I remember having a professor in chiropractic college who said, "When the doctor is ready, they will come." And I guess I'm ready, because my practice is literally booming with kids with not only autism, but kids with Pans and Pandas. So, all right, next slide for me. So in terms of my background, so I started my career working with kids with autism right out of college. So I spent several years working for the Judavine Center for Autism. It now has a different name, but I served families all over the state of Missouri. I traveled all over, saw every kind of kid you can imagine. So, but once I was sort of exposed to the concept that autism is more than behavioral, that autism has environmental factors, I was hooked. I went to what was then called a DAN conference. And from that minute on, I knew that I had to do this. So I left my job, I went back to school, became a chiropractor as a second career. And so now I have a private practice right in the middle of Missouri, and I focus on kids with autism, Pans and Pandas, and pretty much anything else you can imagine. So usually I'm, you know, the many doctors later, they come to see me when they, you know, can't figure out what's going on with their child. So definitely what the Lord put me on the earth to do. So in terms of my personal life, you can go ahead and advance. So I have a sweet husband named Shannon. He's a CPA. You see the dog there, that's our English Bulldog Lola. And that's my daughter in the top corner playing a bass guitar. She actually plays 12 instruments fluently. So yeah, I know most people are like, "Oh, you're not telling the truth." I'm totally telling the truth. So she's pretty amazing. She participates in the School of Rock program in Kansas City, which is a couple of hours from us. So we keep the road hot between here and Kansas City. So, and then the bottom picture is my son, Rowan. He's 15, he's 6'5.5". That half is very important. And he's a theater guy. So he's amazing at theater makeup and special effects and costumes and acting and all of that. So in terms of what we're going to cover today, you can advance for me. Thank you. So we're going to talk about just, of course, what it is, but specifically those acronyms, because there are a lot of acronyms that get thrown around. And so I really want you to understand when you hear the phrase or the term, I want you to know what it means. And I want also to cover very specifically the symptoms, the diagnostic criteria, how doctors come to a diagnosis of this, how many kids are affected, you know, how old it typically is. Because if you're a practitioner, these are kids who are coming into your practice, right? And usually you will see these kids far more often than their pediatrician will. And so as a holistic practitioner, we tend to be better listeners. So parents will often tell us things, and we can pick up on what's going on with kids in a way that other more traditional practitioners can't or don't. So understanding the symptoms, the criteria, the average age of onset, the common triggers as well. So this is a really tricky situation, Pans and Pandas. So lots of different triggers. So you have to really understand the ins and outs. You have to understand what labs to do. If you're a practitioner, if you're a parent, you need to know what to ask for. You need to be educated on how to advocate for your child. And then both traditional and holistic approaches to treatment we're going to talk about, and then kind of what the end game is here. What can you expect from getting this diagnosis, from having this specific treatment. All right, so the acronyms. So you hear PANS, PANDAS, right? So PANS stands for Pediatric Acute Onset Neuropsychiatric Syndrome. And so PANDAS is basically the same thing, except it's associated with strep, a strep infection. And that's primarily what we're going to talk about today, but I will talk about some more of the non-infectious triggers as well. Occasionally, you may hear the acronym PITAND, which stands for Pediatric Infection-Triggered Acute Neuropsychiatric Disorder. And then the newest, and probably kind of in my opinion, one of the best ones, is CPIE, which stands for Childhood Post-Infectious Encephalitis. All right, so let's kind of see how all of this fits together and how it's related. So when we start with considering everything as PANS, so PANS, Pediatric Acute Onset Neuropsychiatric Syndrome, is really sort of an umbrella. And from there, we can have infectious triggers and we can have non-infectious triggers. So the infectious triggers can be things like strep. They can be other things too. So viruses, including the flu, Lyme, parasites, candida, mycoplasma. So really any sort of infectious pathogen can trigger PANS with an infectious trigger, okay? Also, we have non-infectious triggers. So these can be things that come from the environment. So toxins, mold, heavy metals, and chemicals as well. All right, so in terms of this diagnosis, it is very commonly missed. Over half of kids with PANS will be misdiagnosed and mistreated or untreated for over a year. And when you're talking about a child's life, a year is a really long time, right? And so most are misdiagnosed as having, number one, absolutely would be a psychiatric illness. Because as I'm going to talk to you about later, a lot of the symptoms really do look psychiatric. And so most people who are giving psych diagnoses are not educated on Pans and Pandas. So how can they give a diagnosis of which they're not educated on? So it's also very often misdiagnosed as just behavioral problems. They have a conduct disorder, they have oppositional defiant disorder, they have autism, any number of things that really sort of dialed down in terms of blaming it on just a behavioral issue. And then many of the families who have come to me have had professionals say, this is your fault. You're a rotten parent. You're too lenient, you're too this or too that, or not enough this or that. And so your child behaves this way because you're a poor parent. Not true. Most of I can really say all of the families who've ever come to me, they're amazing people. The things that they are able to cope with and support their child through is astounding. So, and as I mentioned before, functional health folks like us, practitioners, we play a vital role in recognizing these kids and teenagers who may be exhibiting symptoms consistent with PANS or PANDAS. And so we need to be able to, again, to recognize it and sort of start that ball rolling, start that conversation toward getting an appropriate diagnosis. All right, so in terms of a diagnosis, remember that PANS is a neuroinflammatory autoimmune encephalitis that can have multiple triggers that are both infectious or non-infectious. So autoimmune, brain swelling. So symptoms can vary. And this is where a lot of doctors get hung up, is they have a really strict guideline. They have blinders on when it comes to how to diagnose these kids. So if they are not a perfect, square peg in a square hole to be able to check all those boxes, then they kick out the possibility of Pans or Pandas. But symptoms vary child to child. They do not always present as acutely or as dramatically as some of the literature explains. And so really my working approach is that a diagnostic workup should be considered in any child with a new onset of symptoms or in kids with multiple current diagnoses. So if you have a kid who walks in your office and they have a laundry list of different diagnoses, really Pans and Pandas should be ruled out. All right, so let's talk the specific diagnostic criteria. So what we see is an abrupt onset or an abrupt recurrence of compulsive behavior, obsessive thoughts. So remember, an obsession is a thought, a compulsion is a behavior. And so what I frequently see in my practice, hand washing, hoarding. Hoarding is a big one. And I really see multiple kids who hoard cardboard, paper, that kinds of thing. And they will, excuse me, they will hoard these things under their bed, in their rooms, in the nooks and crannies of their bedroom. It doesn't necessarily have to be paper and cardboard, but that is a really common one that I see in my area. Also checking, so checking the faucet, checking the stove, checking that doors are locked or closed or cabinets are closed. Excuse me. Also making sure things are in the right order, that things are symmetrical. Repetitive questioning is a big one too. So asking the same question over and over, even if they know the answer, as well as counting, having to count their steps or count the number of tiles between this room and that. So lots of issues around compulsive behavior. We also really frequently see restrictive food intake. So these are kids who will just stop eating, or they become incredibly limited in what they eat. Now, this is something that is really consistent across kids with autism. And so it's something you have to sort of tease out when you're working through a diagnosis. When you can understand the reasoning behind it, it helps you kind of figure out where this is coming from. So many times the restrictive in food intake is because of a fear of vomiting, a fear of choking is another one, fear that the food is contaminated and will poison them, fear that someone is actively poisoning them, and then sensitivities to either the taste, smell, or texture. In order to meet the diagnostic criteria for Pans or Pandas, you have to have at least two of these following things. Anxiety, and remember, this is an abrupt onset or an abrupt recurrence of these things. So severe anxiety, sensory amplification. So again, sensory issues are really common in kids with autism, but this is a new onset, new abrupt recurrence. And so these are kids who will say, they hear every little thing. They can't stand to hear dad chewing his dinner at the dinner table, right? Things are much more intense, much more difficult to live in the world because of the sensory amplification. And then we also see very evident emotional lability. So they're up and down, they're 0 to 60 in no time, or this new onset of depression. We also see irritability, oppositional behavior, sometimes even aggression from these kids. We also really commonly see a behavioral and or a developmental regression. So these are kids who revert back to baby talk. They revert back to being super clingy with their parents or their siblings or their grandparents. We see a new onset of separation anxiety from their caregivers, lots of tantrums. And so basically behaviors that they made it through developmentally appropriately, they are now regressing back to. And then we also see what we call motor abnormalities, particularly vocal or motor tics. So a tic can be anything that's repetitive and uncontrollable. So what I see a lot is throat clearing, coughing. I've got several kids who will open their mouths as wide as they possibly can and close them again over and over. Lots of blinking, or blinking really tightly and then opening their eyes really, really wide. Kids who will have a tremor in their face, or a tick with their mouth, or a shoulder shrug, or any number of things can be a tick. Those are the common ones that I see in my practice. We also see what are called choreoform movements, so uncontrollable movements of the arms, of the legs. We also see what is called piano fingers, and this is one of the tests actually that I do when kids are with me in the office. So to test piano fingers, I just have the child, if they're able, hold their hands out flat, and you can see, if you try it yourself, you'll find the same thing, that you can hold your hands still. If a child has this autoimmune encephalitis, what happens is when I ask them to do this, they do this. Their fingers move as though they're playing a piano. We also see an onset of dysgraphia. So difficulty with handwriting. Handwriting is very difficult, laborious, and so we notice a very distinct change in their handwriting skills. Also, urinary symptoms. So this is, if a parent calls me in a panic, this is one of the first questions I ask. Has their urine behavior changed? Because what we will see is kids who will suddenly, abruptly, start wetting the bed after they were dry at night. They will start wetting their pants at school or on the playground. We will see urinary frequency. So a kid who's to and from the bathroom constantly. So any kind of change in frequency or habits, and then as well change in sleep disturbances. So kids who were sleeping just fine, now they're waking up early, they're having trouble going to sleep, staying asleep all night. All right, and so we also have somatic findings with these kids. So very frequently, because this is encephalitis, right? It's affecting their autonomic nervous system. And we will often note that they are really stuck in that sympathetic dominance, so stuck in the fight or flight. And so we see changes around that, specifically dilated pupils. So parents will call me and say, Johnny's pupils are as big as dinner plates. We must be in a flare, because that's one of the first things that will show. Again, that onset of clumsiness, a change in gait, any sort of choreoform movement, and then changes in reflexes as well. And one of the things I'm going to talk about here shortly is the importance of a really thorough physical exam, because these are things that are really actually quite clear upon a very thorough physical exam. So we see changes in reflexes. So there may be hyperreflexia above the waist and hyporeflexia below, or it may be different from left to right. We also see changes in the eye's ability to be equal and reactive to light and accommodation. So when we do the Perla exam, we definitely see differences in that, as well as eye tracking. So we see kids who are unable to follow the finger. When they do, maybe they show nystagmus, things like that. And then deterioration of school performance, particularly in handwriting, like I just mentioned, the new onset of dysgraphia. So we see deterioration in their handwriting and math. It doesn't have to be those two things. It's just what we most commonly see. So here's an example of differences in handwriting during a flare and not in a flare. So you can see the picture to your left, and within that, the left-sided picture. Pretty nice handwriting for a child, but during a flare, you can see their handwriting falls apart. The two pictures to your right, this is actually a patient of mine. And so when he is in a flare, he doesn't necessarily, I mean, you can tell with where the green handwriting is, that his ability to write is actually still pretty good. He makes his letters quite nicely, but he has a compulsion to write as many verbs as he can think of, and he just writes one on top of the other. So this is his handwriting on the far right when he is not in a flare. All right, so in terms of age of onset, the literature says between 3 years and puberty. However, I have seen so many patients in my practice who are older, who are maybe 15, 17 years old. We need to see an acute onset with a relapsing remitting course. That relapsing remitting course we call flares. Okay, so sometimes the onset is not an overnight onset. It's not super acute. Sometimes it's a more insidious onset. So if it barks like a dog and it runs like a dog, we're going to call it a dog, right? Even if the onset isn't maybe super acute. And then, of course, we want to make sure that symptoms aren't better explained by another neurological or medical disorder like Sydenham's chorea, like lupus, or Tourette syndrome, toxic effect of some sort of prescription. Okay, so we talked about triggers. So we know we can have infectious triggers. We know we can have non-infectious ones. The very most common trigger is a strep infection. So in 81% of kids who were studied, the trigger is strep. And so what the literature tells us is that patients who have OCD, Tourette's, or another tic disorder are more likely than controls to have had a prior strep infection 3 months prior to onset. Okay. Higher risk among those who had multiple strep infections over the last 12 months. And so the more strep infections a child has had, the more likely they're going to have more frequent flares as well. And this is super important because patients often have a history of never having a sore throat, yet being diagnosed with strep. So we can't just rely on, oh, my kid's never had strep, he's never had a sore throat, because so many of these kids have such a dysregulated immune system that they have a strep infection, but they do not present it classically. So they don't always have a sore throat. They don't always have a fever. They don't always have abdominal pain. And so we have to not just rely on that sort of data. Other triggers, and people are always surprised to hear about this one, tooth or dental issues. So there's a huge amount of strep in the mouth. And so anytime a child has a loose tooth, a tooth that has fallen out, a new tooth that's erupting, and even sometimes invasive dental work, a cleaning, a filling will often trigger a new onset of Pandas symptoms or flare. So when parents call me saying, "Oh, my kid has fallen apart, what on earth is going on?" I say, "Do they have a loose tooth?" "I don't know." "Well, look," and I'll have parents look, and most of the time, what we see is a wiggly tooth in there, and that is the trigger. So we also see that these kids are super susceptible to mold toxins. Also a variety of other bacteria and viruses. So mycoplasma, influenza. Most of the kids I test have a very high viral load, particularly of HHV6, Epstein-Barr, and Coxsackie. Those are really, really common. We also see herpes simplex as well, but these are some of the top things that I find on labs. We also see cytomegalovirus, also known as CMV, parvo. We see a lot of Klebsiella in the stool of these kids, as well as yeast, parasites. When we test for Lyme, it's really common to find Lyme. And then these are also kids who tend to be triggered by sinus issues. So during times of high allergy issues in the environment, usually kids with Pans and Pandas have a much more difficult time. These are kids who also frequently have MARCONs. They have that staph colonization in their sinuses. So lots of sinus issues, lots of allergy issues will trigger our kids as well. So in terms of incidence rate and age of onset, so they're saying at least 1 in 200 kids have pandas. However, there are so few doctors who know what they're looking at when this is staring them in the face that it's likely quite a lot more than that. Average age of diagnosis, according to the literature, is between 4 and 13, and it is not always concurrent with the diagnosis of autism. There are kids in my practice who were just absolutely neurotypical. You know, they were on the football team, they were student council president, and they get an undiagnosed strep infection that triggers pandas, and things fall apart for them. All right, so what's happening when this is going on with a child? Really, what it all boils down to is that the strep infections will trigger production of antibodies that cross-react against the central nervous system that cause inflammation, tics, and compulsive behavior. It also seems to result from an immune response that sort of took a wrong turn, right? So we went from something that should be fairly benign, like a strep infection, and the body just took a detour. And now we are looking at an autoimmune process that specifically triggers the basal ganglia in the brain. And so that really seems to be the common theme, is the way that these pathogens affect the basal ganglia, because it causes inflammation, and then that part of the brain can't function the way it's supposed to. We also see that there is the nasal associated lymphoid tissue has a direct line to the brain from the nose. And so when we talk about kids who have MARCoNS and allergies and sinusitis, it seems to be that the group A strep has a direct line from the nose right to the brain, breaks down the blood-brain barrier, causes microglial activation, and then here we are with these behaviors. We also see that when people get the flu vaccine, it tends to change the microbiome of the nasopharynx area, the sinus area, and it allows strep and staph to get in there and do its damage. And then we also see that the vast majority of patients with Pans and Pandas have at least one first-degree relative who has an autoimmune issue. All right, so what I tried to do here was sort of put all of this together in one picture for you. So you can see that we've got our infectious triggers on the left: bacterial, viral, fungal, parasitic. We have our non-infectious triggers on the right: mold, dental stuff, vaccination, anything that pokes the bear in terms of the immune system, right? So this causes excess antibodies that then causes basal ganglia inflammation, which then leads to this cascade of behaviors. Take your pick, right? It can be any of these, it can be all of these. And so you can see just how complex this is and what a long path to diagnosis it might be when you have to sort of check every box and rule out what all of the potential triggers might be. All right, so now in terms of the workup, so you know, I'm a doc, so this is where my mind goes. How do we figure this out? So if though you're a doc and you want to sort of get into this, this will give you a framework of where to begin. If you're a parent and you suspect this in your child, you need to be versed in this, right? You need to know how to advocate for your child and what kinds of things to make sure happen. So it's really important that we have a thorough history on this child, particularly around exposures to contagious illness, as well as a thorough physical exam. Now, these aren't always kids who are easy to do an exam on, right? Sometimes they have autism in conjunction with Pans or Pandas. Sometimes the symptoms that they're exhibiting make it difficult for them to cooperate with you while you do this physical exam, but it's absolutely necessary to do whatever you have to do to make it through a thorough physical exam, including neurologicals, doing, you know, all of the sensory tests, doing all of the tendon reflexes, looking at skin for any sort of rash, any kind of symptom that some deeper things are going on. And then looking at the throat. So remember that strep infections are often found without having a sore throat. Even without the sore throat, the body will generate the antibodies against strep. So doing rapid strep testing and nasal throat rectal cultures are a great way to start. Most kids can tolerate this pretty well. Also an immune system history. So these are often kids who have a very dysregulated immune system to begin with. So parents will say, oh, he never gets sick. Well, that's not a badge of honor, right? You're supposed to get sick at least occasionally, right? It shows us that your immune system is working. So for the kid who gets every last thing, or for the kid who never gets sick, right, that's important to know. And then of course the nervous system history as well. These are kids who often are stuck in sympathetic dominance chronically. They're kids who maybe rarely get fevers. So it just, all of this gives you clues as to what could be happening. And so our kids need labs. Often parents are refused labs because it's just autism or it's just a behavior disorder, but they need basic labs like a CBC and a CMP. We need to know their vitamin D levels. Also, total cholesterol is very important, particularly in kids with autism and kids with pandas, because what we find is that their total cholesterol is actually quite low. And when this happens, then it changes the body's chemistry and we end up with behavior issues. All right, also things specific to strep. So all of these issues, we need strep, antibody titers, rapid strep swab, cultures if necessary. And then I also frequently do stool tests because strep will show up on a stool test. It's important to note that throat swabs, a rapid swab, and throat cultures will often give us a false negative because the strep bacteria is so deeply sequestered in the tonsillar tissue. So what I like to do is do initial blood work and then repeat that in 6 to 8 weeks to see if those antibodies are going up or down. And if urinary symptoms are present, I always try to do a urinalysis as well. I like to do viral panels for all of the different virals that I talked about before. So herpes, Epstein-Barr, CMV, Coxsackie, etc. I also frequently do mycoplasma, try to look at Lyme and the co-infections, Marcons, and a Cunningham panel if it's in the budget for the family to do that. It's a fairly expensive test. And so if all antibody levels are negative and no infection can be found, right? So if we've checked every box, then we start looking at non-infectious things like heavy metals, like chemical exposure, etc. And so in terms of labs for non-infectious triggers, I frequently will use Great Plains Labs. That's really my favorite, the mycotox profile. Genova, Great Plains Labs, Doctor's Data, those are labs that I use consistently for a variety of things. For chemical exposure, the Great Plains Lab has something called the Envirotox profile that will give you page after page of where they stand in terms of chemical exposure. All right, so if a child is diagnosed with pandas, everyone in the family needs to be tested. If it's an infectious trigger like strep, what you don't want is for everybody else in the family to also be carrying this and just passing it back and forth, okay? So I usually do a throat swab and then blood work on the rest of the family as well. All right, so in terms of traditional treatments, it depends on the pathogen, right? So if it's bacterial, their pediatrician may choose to use antibiotics, maybe steroids, maybe anti-inflammatories. If it's a viral trigger, they may use a prescription antiviral. There are some doctors who believe in what's called the tincture of time. I am so wholeheartedly against this. Things just don't naturally get better, right? This is a really serious disorder. and it's not something you want to sit on. So I disagree with tincture of thyme. Sometimes families will choose to do IVIG or plasmapheresis. Sometimes having tonsils and adenoids out is a positive thing. As a general rule, I'm in favor of keeping all organs. But I have seen many, many kids with pandas whose outcome improves when they have their tonsils out. All right, so in terms of more interventions, holistic interventions, kind of the most common place to start is ibuprofen. It's an anti-inflammatory. It really helps dampen behaviors. Of course, depending on what kind of practitioner you are, you have to stay within the bounds of your license, right? And so I advocate for the natural counterparts of these. I have a whole list of things that I send families. And so what this anti-inflammatory does, along with Benadryl or a natural antihistamine, it cools that encephalitis and it slows down that immune system overreaction and just really gets kids feeling better so that we can get in with more long-term types of treatment. I really, really frequently use homeopathy. So it depends on the child, it depends on their trigger, but I find the right remedy. I usually pair it with a drainage remedy because these are often kids who don't detox very well. And so when we can put some drainage in there, it helps move those things out. I really like homeopathy because it comes in different formats. And if you've got a kid who won't take anything by mouth, then you can use things like the suppositories. I use a lot of herbs, like cryptolepis, red root, Chinese skullcap. All of those are super effective. Other things that help, there's a long list here, vitamin D, probiotics, anything that you're going to do to improve the gut is going to help. I really like Biocidin toothpaste. It helps keep that bacteria in the mouth under control and keeps us from having too many flares. And then what can you expect? So for many kids, improvement is swift, but really it takes time, right? It takes time and patience, and you have to understand that flares are probable. So kid we'll get them doing really well, and then all of a sudden something happens and their behavior flares again. And that may happen repeatedly. Sometimes the flares are intermittent, sometimes the flares last a long time. That's why families need a practitioner to hold their hand through this whole process. So there's some amount of controversy about Pans and Pandas. There are doctors who believe it's not a thing, right? Even though there are scads of research to look at. Families have a difficult time finding a doctor. If they do find a doctor, sometimes they're too strict in terms of the diagnostic model that they follow. But the bottom line is it's a real thing, and there are tons of kids who have it who need help. So remember this, if nothing else, multiple diagnoses in a child, if they've got a whole list of diagnoses, then this should be a red flag to the doctor and should consider a Pans and Pandas workup. We have to think about school accommodations, right? So these are kids with lots of anxiety, lots of behaviors, lots of compulsions. They've lost their hand skills, they've lost their math skills, right? So school needs to be involved. Families need some help educating teachers and administration. That pain is a common comorbidity here. And so chiropractic is a fantastic adjunct treatment. Kids need a multidisciplinary team. So in terms of my contact information, so if you have any questions about, hey, I've got this kid in my house, I don't know what to do, or hey, I need a doctor for my kid, this is my contact information. Email is definitely the best, Dr. Sonia at drsoniamcgowan.com. More than happy to share my knowledge and all my years of experience with really tough, challenging kids. And the rest is just references, so there are a lot of them. There's a lot of literature out there about Pans and Pandas.
Well, Sonia, this was great information, a great refresher from last time. I really enjoy learning about this, and very specific to this topic, and really unique ways to define this. Like you talked about things like a loose tooth and all those things. That's why it's really important to have a practitioner and an educated practitioner like yourself, where you know what to look for. And sometimes parents, you talked about pet parenting, can be a blame for some of this, when that's not the case at all. You said a lot of parents that bring their children in, they're concerned, they have these this great notion that something isn't right with their child, so they bring them in. And knowing all of the things that and what to look for, like those unique things and the changes in their behavior, can really tell a lot. So that's really great. We do have a question someone asked who is following along with this, asking, what is the natural equivalent to Benadryl? Maybe in the stance of what you were referring to.
Mm-hmm. So probably, I mean, I have a few. I would say probably DHIST or DHIST Junior from Orthomolecular is one of my top choices. Quercetin is also another really good choice as well. There are also some natural, actually some homeopathic antihistamine remedies. Pacana has a whole line of homeopathic liquid remedies. And they have a few that are specific to sort of cooling off that histamine reaction.
Well, that's great. And everyone has your contact information here to reach out to you if they have further questions. And I just thank you for your time. Being able to connect with you through this virtual summit is awesome. And next time we might do a hybrid of live and virtual. And I know you're not in the Pittsburgh area, you're way far away. So maybe we'll bring you back again to have you on this. So I just thank you for your time. And anything else you want to leave us with?
Oh, well, I just appreciate your including me, and I appreciate everyone in the audience and their attention. And I really hope that it kind of got folks thinking and helped them understand a really complex topic. It's something that we could talk about for a few hours. So to condense it down into just a few minutes is challenging, but it definitely, hopefully, gave you some ideas about what to look for.
I think you did a great job. And one last comment we got from one of your patients that commented and said, we work with Dr. McGowin and highly recommend her. She's very caring and helpful. We saw improvements with our son in just a couple of weeks. He's so happy now. So I hope that makes you smile, and people understand the work that you're doing and just changing people's lives. These things can be so time consuming and so frustrating and stressful, but with people like you, they're overcoming that. So awesome job, and thank you so much.
Thank you so much. Have a good day.
You too.
Bye.